Usually, when we talk about structural engineering, there is this underlying expectation of, rigid, predictable precision.
Oh, absolutely.
Like you're building a bridge, you need it to bear a specific load, so you pour concrete and you lay steel. It's visible, it's measurable, and above all, it's static.
Right, it just sits there. Yeah.
Exactly. But the moment you step into the world of human biology, and specifically, the aesthetic and functional reconstruction of mucosal tissues, that entire rigid engineering framework just completely collapses.
It really does. I mean, we're talking about a landscape of materials that have to be incredibly dynamic.
Right, highly adaptable.
Yeah, and capable of integrating flawlessly into a host environment that is actively, trying to break them down 24/7.
Which brings us to the core mission of today's deep dive. We are unpacking a topic that is, frankly, heavily searched and endlessly whispered about, but very rarely scrutinized with actual clinical clarity. We are answering a very specific question for you today. What exactly goes into the body during intimate cosmetic procedures?
And because you're listening to this, we already know you are well past the basics.
Right. You don't need us to explain that hyaluronic acid is a naturally occurring glycosaminoglycan.
Exactly. We're stripping away all the taboo, completely bypassing the marketing jargon, and looking purely at the molecular science.
The clinical protocols and the really strict new UK regulations surrounding these highly specialized materials.
And to do that, we are drawing from a really specific stack of sources today.
Yeah, we've got some fascinating stuff.
We do. We're looking at aesthetic clinic protocols, detailing the exact chemical breakdown of products like Diserial and Novia Rose. We're also pulling from the NICE-E guidelines, that's the National Institute for Health and Care Excellence, regarding non-absorbable polymers.
Right.
And crucially, we are dissecting a brand new UK government press release detailing a major regulatory crackdown on this entire cosmetic sector.
So let's just set the baseline immediately. When we use the term intimate filler, we are not talking about a clinic taking a standard dermal filler meant for cheekbones and just haphazardly repurposing it for the body, right?
No, definitely not.
Because if hyaluronic acid, or HA, is the universal base ingredient, I really want to drill into the rheology here. Why are the clinic protocols explicitly demanding entirely different chemical formulations for the labia or the penile shaft compared to, say, the face?
Well, it fundamentally comes down to friction.
Friction.
Yeah, friction and the local metabolic environment. I mean,
Wow.
the tissue in your lips or your cheeks behaves entirely differently from the tissue in the labia majora. A cheek filler sits over a rigid bone structure.
It's relatively static.
Exactly. But intimate tissues face constant mechanical friction, significant temperature fluctuations, and just intense structural demands.
Because they have to stretch and compress repeatedly.
Right, without losing cohesion. So manufacturers have to heavily customize the cross-linking, the chemical bonds holding the HA polymer chains together just so the gel can survive that completely hostile environment.
Okay, so let's unpack what that chemical customization actually looks like in practice. Because I was looking at a product like Diserial, which is heavily cited in our clinical sources for vulvovaginal application.
Yep, very common one.
And it contains the standard HA at about 19 to 21 milligrams per milliliter. But they specifically formulate it with an additive called mannitol.
Mannitol, yes.
Now, mannitol is typically utilized as an antioxidant. So my assumption reading through the protocol is that they're adding it to act as almost a biochemical shield against the inflammatory response triggered by the needle itself.
That is a highly accurate read of the mechanism.
Yeah.
Because when a practitioner drives a cannula or a needle into delicate mucosal tissue, they're inevitably causing microtrauma.
Right, the body's going to react.
Exactly. That trauma triggers the local immune system, causing neutrophils to rush to the site and just dump reactive oxygen species or free radicals to clear out the damaged cells.
And those free radicals are highly aggressive.
Incredibly aggressive. They will violently cleave the polymer chains of the freshly injected HA. They literally degrade the filler before it even has a chance to settle in.
Oh, wow. So the mannitol is essentially acting as a sacrificial lamb.
That's a great way to put it.
It neutralizes the reactive oxygen species, kind of taking the chemical hit so the hyaluronic acid crosslinks remain intact.
Precisely. It mitigates the post-injection redness and swelling,
Right.
but structurally, it protects the longevity of the HA matrix, so that targeted hydration lasts significantly longer in the mucosa.
That is fascinating. And then you have formulations that push the structural boundaries even further, like Nuvia Rose.
Oh, yes. Noia Rose is an interesting one.
The protocols show this is engineered to be an incredibly thick, highly viscous gel, and it boasts a massive HA concentration like 28 milligrams per milliliter.
Which is very high.
Yeah. But what really caught my eye is the inclusion of two specific amino acids, glycine and L-proline. Because if we look at the molecular structure of human tissue, glycine and L-proline are the two most abundant amino acids in the collagen triple helix.
Right, they are the absolute foundational building blocks of collagen.
Okay, so why put them in the filler?
Well, by suspending those specific amino acids within a high-density HA gel, the product stops being just a mere space occupier. It actually becomes a biostimulatory scaffold.
Wait, a scaffold?
Yeah, so the hyaluronic acid creates the physical volume and stretches the local fibroblasts. Those are the cells responsible for producing structural proteins. And when those fibroblasts are stretched, they are mechanically activated.
Okay.
The gel then conveniently provides them with the exact raw amino acids they need to synthesize new collagen fibers.
So it's essentially setting up a biological construction site and dropping off a truckload of bricks for the local workers.
Exactly. And the manufacturers approach this integration in different ways, like the Regenio Harmonia specs detail a really gentle, multi-density cross-linking process to create what they term a 3D matrix.
Right, I saw that.
It seems the goal there is to avoid the Tyndall effect or any palpable lumpiness by creating varying molecular weights of HA that just slip seamlessly between the delicate tissue planes.
So the clinical goal is indistinguishable integration.
Exactly. The multi-density approach mimics the body's natural extracellular matrix.
Yeah.
The critical takeaway from all these HA protocols is that these aren't just dead gels. They're biologically active environments.
They provide immediate volume, but they're actively stimulating what? Neocollagenesis?
Yes, over a period of 6 to 18 months before the body eventually metabolizes the gel.
But, I mean, that metabolic breakdown is the inherent limitation of HA, right?
Right. It's temporary.
Even a beautifully cross-linked 18-month scaffold eventually degrades. So when a patient just refuses to return for endless top-ups, the clinical conversation inevitably shifts to permanence.
Which is a whole different ballgame.
Exactly. And that brings us to autologous tissues and synthetic polymers. So let's start with the biological route, autologous fat transfer.
Right.
The literature focuses heavily on nanofat grafting. We aren't just taking pure, unrefined adipocytes from the inner thigh and relocating them. The critical mechanism here seems to rely on isolating the stromal vascular fraction during the centrifugation process.
Yes, the stromal vascular fraction, or SVF, that is where the regenerative magic actually happens.
That exactly is in it.
Well, if you simply inject raw, unprocessed fat lobules into an area with poor blood supply, the fat cells will undergo necrosis.
Yeah.
They just die and reabsorb.
Oh, yikes.
Yeah, but by spinning and mechanically filtering the harvented fat, the surgeon isolates the SVF, which is an incredibly dense, concentrated cocktail of adipose-derived stem cells, endothelial progenitor cells, and growth factors.
Okay, so when that SVF-enriched nanofat is re-injected into the labia or the penile shaft, the stem cells actively trigger neovascularization.
Exactly. They establish a brand new, permanent capillary network to feed the transplanted tissue.
So you're permanently rebuilding the structural integrity.
You are.
But obviously that requires surgical liposuction and, significant downtime.
It's a full surgical procedure. Yeah.
Which brings us to the synthetic, non-surgical route for permanence. And this is where our sources indicate the materials cross the line from innovative engineering to outright physiological danger.
Oh, absolutely. This is where the biological architecture we discussed earlier completely fails.
Right.
Historically, and in some highly specific reconstructive cases today, practitioners utilize non-absorbable gel polymers, or NAGPs.
Yeah, we saw these detailed in the NICE guidelines. They originally reviewed the use of NAGPs, which often contain synthetic polyacrylamide, for treating HIV-related facial lipoatrophy.
Yes.
And these are water-based synthetic hydrogels that permanently sit in the tissue. But I have to ask about the cellular mechanics here. Why is the immune system utterly incapable of breaking down polyacrylamide? I mean, macrophages routinely clear out foreign debris. Why do they fail against these polymers?
It's purely a matter of chemical recognition and sheer molecular size. The polymer chains in polyacrylamide are massive, tightly woven, and entirely synthetic.
Okay.
When a macrophage arrives at the injection site and attempts phagocytosis, trying to literally engulf and digest the material, it finds that it lacks the specific proteolytic enzymes required to cleave those synthetic bonds.
So it just can't break it apart.
Right. The material is completely chemically inert to human enzymes.
Yeah.
So the polymer remains permanently lodged in the interstitial spaces.
Wow. Okay, so if permanent non-absorbable polymers exist, the obvious question arises, why wouldn't a patient looking for a cheaper permanent enhancement just utilize liquid silicone? If polyacrylamide is inert, why is free silicone so catastrophic?
Right.
Because the British Association of Aesthetic Plastic Surgeons, BAPS, they issue incredibly severe, unequivocal warnings banning the injection of free liquid silicone.
The operative word in that warning is free.
Free.
Yeah. We utilize silicone safely in medicine constantly, but it is almost always contained. Like a breast implant features silicone housed within a highly engineered, durable elastomer shell.
Right. So the immune system recognizes the shell, forms a fibrous capsule around it, and the material is just quarantined.
Precisely. But when an unlicensed practitioner injects free, uncontained liquid silicone directly into penile or labial tissue, there's no boundary.
And because the tissues in those regions are highly vascular and subject to gravity and constant mechanical friction, that liquid silicone migrates along the fascial planes.
Yes. It doesn't stay where you put it.
It just drifts.
It migrates relentlessly.
Yeah, good.
This triggers a catastrophic histological cascade.
Okay, what does that look like?
Well, the macrophages attack the free silicone droplets. But as we discussed, they can't digest it.
Yeah.
But instead of remaining inert, like the polyacrylamide, the frustrated macrophages secrete heavy inflammatory cytokines.
Basically signaling for reinforcements?
Exactly. Dozens of immune cells arrive, realize they cannot clear the liquid, and literally fuse their cell membranes together to form massive, multinucleated giant cells.
They realize they can't kill it, so they try to build a wall around it.
Yep. They build a thick, fibrotic wall of collagen around the migrating silicone droplets, and this creates chronic, severe inflammatory masses known as granulomas.
Oh, wow.
The patient develops these hard, incredibly painful, disfiguring nodules of inflamed tissue scattered all throughout their anatomy.
Which creates a total surgical nightmare.
Oh, it's terrible.
Because you cannot simply inject an enzyme to dissolve a silicone granuloma. The only solution is severe surgical excision.
Right. The surgeon has to cut out the granuloma.
Which inherently means destroying the surrounding healthy host tissue. You're left with massive scarring and tissue deficits. And knowing that these catastrophic materials are actually in circulation perfectly contextualizes the brand new regulatory crackdown we analyze.
It was an entirely unregulated free-for-all for a while there, which led directly to the August 2025 UK government press release spearheaded by the Minister of State for Health, Karen Smith.
Yeah, the press release does not mince words regarding the severity of the crisis. Under their new plan for change, the government is officially dismantling what they explicitly call the Wild West of dodgy practitioners and cosmetic cowboys.
I love that phrasing.
Right. They've implemented a new risk-based classification system, and intimate fillers, specifically any dermal filler injected into the genitals or breasts, are now officially designated as highest risk procedures.
And that highest risk designation carries profound legal weight. It mandates 3 sweeping changes.
Okay, lay them out.
First, these procedures are now legally restricted to suitably qualified healthcare professionals. The era of a layperson taking, like, a weekend certification course and injecting HA or polymers is over.
Thankfully.
Second, these injections can only take place in facilities registered with the Care Quality Commission, or CQC.
And a CQC-registered facility is vastly different from a pop-up clinic in the back of a salon or a hotel room.
Vastly.
It requires strict adherence to aseptic techniques, emergency anaphylaxis protocols, and verifiable clinical hygiene standards.
Exactly. And the third mandate is an absolute ban on under 18s receiving these highest risk procedures unless authorized by a physician for a specific medical necessity.
What I found particularly compelling about the government's intervention wasn't just the focus on patient safety, but the underlying economics.
Oh, for sure.
Because the taxpayer has been unknowingly funding the flow out of this unregulated industry. When a patient receives a cheap, illicit polymer or silicone injection in a hotel room and develops necrotic tissue or systemic granulomas, they inevitably present at an NHS emergency room. The public health system has been bleeding millions of pounds, funding complex, multi-stage reconstructive surgeries, and severe infection management caused by unqualified practitioners. So forcing these procedures into highly regulated, CQC-compliant medical environments is basically an economic tourniquet for the NHS.
It really is. It shifts the burden of risk and safety squarely back onto regulated clinical professionals, effectively cutting off the pipeline of illicit complications that are just draining public health resources.
So we've dissected the materials from the biochemical engineering of hyaluronic acid and the regenerative angiogenesis of nanofat and the absolute dangers of migrating synthetics.
We covered a lot of ground.
We did, and we understand the legal barricades now in place, but we really need to look at how these highly engineered materials actually function in the real world.
Right, the clinical application.
Because if you scroll through social media, the algorithmic marketing frames these treatments as purely vanity-driven, designer procedures. But digging into the clinical physics, these materials provide profound functional and medical relief. Let's look at the female application, specifically procedures treating labia atrophy.
The clinical utility here is incredibly impactful. As women transition through menopause or experience significant estrogen drops post-childbirth, the histological structure of the vulvovaginal tissue fundamentally changes.
Because estrogen is vital for maintaining mucosal thickness and elasticity.
Exactly. When it depletes, the labia majora lose their subcutaneous fat, and the mucosa severely thins out,
which destroys the tissue's ability to act as a mechanical shock absorber. Functionally, the labia majora protect the more delicate internal mucosal tissues from friction.
Right.
When that viscoelastic cushion deflates, women experience chronic dryness, tearing, and severe physical pain during basic activities. The physics of the friction shear stress during cycling, horseback riding, or even just wearing tight clothing becomes totally debilitating.
It drastically reduces their quality of life. But by strategically injecting customized HA fillers like Discerial or utilizing SVF-enriched fat transfer, the clinician is literally reconstructing that functional friction-bearing cushion.
And because HA binds up to 1,000 times its weight in water, it restores the mucosal hydration and elasticity.
Exactly, allowing these women to resume an active, pain-free lifestyle. It is a deeply functional, restorative procedure.
Now, the biomechanics of the male applications are equally fascinating, particularly regarding penile girth enhancement.
Right.
The clinical goal is typically a 10 to 15% increase in circumference. To achieve that, protocols mandate high G', densely cross-linked hyaluronic acid, similar to Juvederm Voluma. And crucially, the delivery mechanism is highly specific. Practitioners bypass standard needles entirely in favor of blunt-tipped microcannulas.
Yeah, the cannula technique is a non-negotiable safety standard in this region.
Because of the vascularity.
Exactly. A blunt-tipped cannula glides smoothly through the subcutaneous tissue planes without piercing the complex network of underlying blood vessels.
Which effectively eliminates the risk of intravascular occlusion, where filler accidentally blocks a blood vessel and causes tissue necrosis.
Right. And once that high-density HA is evenly distributed along the shaft, it creates a rigid macrostructural scaffold. It physically prevents the underlying tissue from retracting or shrinking.
Okay, but the true intersection of aesthetic filling and regenerative medicine occurs when clinics combine this HA scaffolding with the P-shot.
Oh, the P-shot, yes, or platelet-rich plasma therapy. It creates a remarkable physiological synergy when paired with HA.
Walk us through that.
The protocol begins with a standard venous blood draw from the patient. That blood is placed in a centrifuge and spun at high velocity to separate the erythrocytes, the red blood cells, from the plasma.
Right.
The resulting serum is incredibly dense with the patient's own concentrated platelets.
And those platelets are packed with alpha granules that release potent growth factors, specifically vascular endothelial growth factor, or VEGF.
Yes.
When this liquid gold is injected directly alongside the hyaluronic acid, the HA provides the immediate structural volume, but the PRP operates on a cellular level.
Exactly. The VEGF actively triggers angiogenesis, the formation of entirely new blood vessels branching off the existing vascular network. For men suffering from erectile dysfunction or the fibrotic plaques associated with Peyronie's disease, this combination therapy doesn't merely alter the physical dimensions.
Right.
The PRP actively breaks down scar tissue, rebuilds the capillary networks, and profoundly improves localized blood flow and functional performance.
It is a brilliant dual mechanism approach. The hyaluronic acid builds the physical house, and the platelet-rich plasma systematically upgrades the internal plumbing.
That's a perfect analogy.
Yes. Well, we have covered an immense amount of clinical ground today. Let's pull the critical data points together. We started by examining the molecular architecture of intimate fillers, discovering that safe, temporary options rely on heavily cross-linked hyaluronic acid,
All right.
acting as a viscoelastic sponge packed with protective antioxidants like mannitol and collagen-building amino acids. We explored how autologous nanofat utilizes the stromal vascular fraction to trigger permanent stem cell neovascularization.
Yep.
We also exposed the catastrophic risks of permanence, detailing how the immune system's inability to phagocytize migrating free silicone leads to severe fibrous granulomas that require destructive surgical excision.
A complete nightmare.
Exactly. Thankfully, the era of unchecked risk is ending. The UK government's August 2025 mandate now rightfully classifies these as highest-risk procedures, restricting them strictly to CQC-registered facilities and qualified healthcare professionals, simultaneously protecting patients and preventing an enormous financial drain on the NHS. And ultimately, we saw that beyond the aesthetic marketing, these highly engineered materials provide critical functional restoration rebuilding friction-bearing cushions for women suffering from labial atrophy and utilizing PRP angiogenesis to restore vascular function in men.
The evolution of these materials is staggering. But, looking at the trajectory of the science we just unpacked, it raises a really provocative question about the future of aesthetic medicine.
Oh,
Because if we are already isolating stromal vascular fractions to harness stem cells and centrifuging blood to extract angiogenic growth factors, the logical endpoint of this field isn't injecting foreign hydrogels at all.
where does it go then?
Imagine a near future where a clinician takes a simple cheek swab to isolate your unique fibroblasts. Using a 3D bioprinter, they could cultivate a perfect, anatomically customized tissue matrix in a lab, entirely seeded with your own genetic material. We wouldn't need to worry about cross-linking HA to survive shear stress or immune macrophages attacking synthetic polymers. We wouldn't be filling the body with external materials. We would be seamlessly installing biologically identical replacement parts printed directly from your own DNA code.
That entirely rewrites the rules of biological architecture. You move from foreign augmentation to true genetic regeneration.
Exactly.
Well, thank you for joining us on this deep dive into the hidden science and molecular engineering of intimate aesthetics. We hope parsing through the clinical protocols and regulatory shifts has given you the hard, unvarnished facts needed to understand this rapidly evolving field. Keep challenging the consensus, keep looking past the surface marketing, and always stay curious.